Welcome to Pharmacology for Nurses YouTube channel. Today we are talking about medications that control the rhythm of the heart, our antiarrhythmics. We're going to talk about how they work, when we use them, and what we need to watch for as nurses. This is a big topic, but I promise to break it down so it makes sense. By the end of this lecture, you'll hopefully understand how these meds help control abnormal heart rhythms and why they sometimes come with side effects and what we need to do as nurses to manage them. Let's get started. Before we jump into the meds, we need to quickly talk about how the heart generates an electrical impulse. The heart's electrical system follows a cycle called the cardiac action potential. It's controlled by the movement of sodium, potassium, and calcium in and out of the heart cells. Any disruption in this flow can actually lead to arrhythmias, a fast heart rate, a slow heart rate, or even irregular heartbeats. This is where our antiarrhythmic medications come in. The first class we're going to dive into is our class 1. These are our sodium channel blockers. So, just by listening to their name, we know that these meds will slow the conduction of the electrical signals in the heart by blocking sodium channels. This makes it harder for cells to depolarize, which slows the heart rate and prevents arrhythmias. We can use this for things like atrial and ventricular arrhythmias, but we have some side effects we need to watch for. This is hypotension, dizziness, worsening arrhythmias, central nervous system toxicity. This is specific to lidocaine. I want to touch on this a little bit more. So, lidocaine is often used for ventricular arrhythmias. It has a unique side effect profile, particularly concerning the central nervous system toxicity. This is because it has the unique ability to cross the blood brain barrier. In excessive levels, it can lead to symptoms like confusion, tremors, slurred speech, and even seizures. As nurses, we need to monitor for these neurological signs, especially when patients are receiving lidocaine IV. Other nursing considerations to be aware of is monitoring that ECG for a widening QRS or prolonged QT interval, checking our blood pressures, assessing for those signs of lidocaine toxicity, and telling our patients what they need to look for. So they should report dizziness, palpitations, signs of toxicity, and avoiding other medications that prolong the QT interval. Class 2. These are our beta blockers, and these come up often in the cardiac section as well. These medications are going to block beta adrenergic receptors, meaning that they reduce the effects of adrenaline and other neurotransmitters on the heart. What is the result of this? Well, it's going to cause a slower heart rate and less excitability. We can use this for atrial fibrillation, supraventricular tachycardia or SVT, and hypertension, but I want to focus on the indications with arrhythmias, like the atrial fibrillation and SVT. The side effects that we see are bradycardia, hypotension, fatigue, and bronchospasm, but this is only with our non selective beta blockers. Let's talk about this for a minute. Beta blockers can be risky in patients with asthma, especially the non selective ones like propranolol. These medications are going to block that beta 2 receptor in the lung and lead to bronchoconstriction. In asthmatics, this is kind of a big deal because it can actually trigger severe respiratory distress. Again, that's why we prefer the selective beta 1 blockers like metoprolol for these patients. Continuing with our nursing considerations, we want to monitor for heart rate and blood pressure. Hold the medication if the heart rate is less than 60, which means we need to be checking a heart rate and blood pressure before every administration, and we need to educate our patients on this as well. So we want to tell our patients not to stop this medication suddenly. It increases the risk of rebound tachycardia. What happens is if this medication is blocking these receptors of neurotransmitters and then the patient suddenly stops taking the medication, well, it's going to allow all of these receptors to be bound to neurotransmitters again. That's going to cause a risk for tachycardia and MI. So they need to taper off this medication if they wish to stop. Our third class is going to be potassium channel blockers. These medications are going to delay repolarization by blocking potassium channels, which ultimately will prolong the action potential and slow the heart's conduction. We use these for atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. The side effects are mostly associated with amiodarone. We can see pulmonary toxicity, liver toxicity, and thyroid dysfunction. We also run the risk of a prolonged QT interval. And the whole issue with this is that if we prolong the QT interval, it can actually turn into a lethal arrhythmia. This arrhythmia is called torsades de pointes. So we need to make sure that our patients are not combining this with other medications that prolong the QT interval and that we're paying very close attention to that EKG. Let's talk a little bit more about amiodarone toxicity. Amiodarone is a powerhouse drug, but it comes with significant risks. It can actually accumulate in the lungs and lead to inflammation, and fibrosis, which causes this pulmonary toxicity. So patients may develop a dry cough, dyspnea, or even pulmonary fibrosis. So we need to do regular lung assessments. It accumulates not only in the liver or in the lungs, but also the liver, leading to hepatotoxicity, which is why we monitor liver function tests like our ALTs and ASTs. And lastly, amiodarone actually contains that iodine, which is why it can disrupt thyroid function. It can cause either hypothyroidism or hyperthyroidism. We as nurses need to be proactive in screening for either of these. So, our patient teaching, what they need to know is they need to report a new cough or shortness of breath, get their regular liver and thyroid tests, and we also need to avoid grapefruit juice. This can affect the metabolism of these drugs. Our class 4 is our calcium channel blockers. Now, calcium channel blockers are going to inhibit calcium influx into the cardiac and smooth muscle cells, leading to decreased myocardial contractility, and it will slow the conduction through the AV node. By reducing the calcium entry, these drugs can decrease the strength of cardiac contractions and lower the heart rate, making them very useful for our atrial arrhythmias. They can also promote vasodilation, which lowers blood pressure. Again, however, let's focus on the indications for arrhythmias: atrial fibrillation, atrial flutter, and SVT. Our side effects are going to be hypotension, bradycardia, dizziness, peripheral edema, and constipation. Our calcium channel blockers can cause significant bradycardia because of their effects on that AV node. We as nurses must check a heart rate before administration. Just like with our beta blockers, we need to hold the medication if the patient's heart rate is below 60. Because these drugs will relax that vascular smooth muscle, leading to vasodilation and potential hypotension, we need to educate our patients on the risks of orthostatic hypotension and the precautions they need to take. Another important consideration unique to this drug is constipation. This results from that smooth muscle motility. Remember, we're blocking calcium channels, and this occurs in the intestines as well. This happens particularly with verapamil. So tell your patients to increase dietary fiber and fluid so that they can mitigate this side effect. Let's finish up by talking about two other medications that don't fit into these other classes. Our first one is digoxin. This is going to work by inhibiting the sodium potassium ATPase pump, which increases intracellular calcium levels in the cardiac cells. This is going to enhance that myocardial contractility, making it very beneficial for heart failure and atrial fibrillation. However, this mechanism also slows the conduction through the AV node, which helps control that heart rate, but does, like some of the other meds we've talked about, increase the risk of bradycardia. Digoxin has a narrow therapeutic index, and this is important because it means we need to screen for toxicity. Signs of digoxin toxicity are going to be nausea, vomiting, visual disturbances, which often comes up on exams. This is like seeing yellow halos, and severe bradycardia. Patients on digoxin require regular serum level monitoring, and we must educate them on the importance of coming for this monitoring. They also need to be educated on the signs and symptoms of toxicity and how they can recognize them when they're at home. Interestingly, hypokalemia will also put your patient at risk for digoxin toxicity. Both potassium and digoxin compete for the same binding site. So if the patient has low potassium, that means there will be more availability of those receptors to bind to digoxin. When we have more bound digoxin, we're going to have increased effects. So therefore, a low potassium equals an increased risk of digoxin toxicity. So in addition to monitoring digoxin levels, we need to be monitoring potassium levels as well. For our final medication, let's talk about adenosine. Adenosine is unique because it works by temporarily blocking the AV node through hyperpolarization of cardiac cells. This is going to activate potassium channels, leading to an efflux of potassium from cardiac cells while simultaneously inhibiting calcium influx. This sudden change momentarily halts conduction through the AV node, effectively resetting the heart in cases of supraventricular tachycardia or SVT. Now, this medication is going to work very quickly. Oftentimes, patients will describe a transient feeling of chest discomfort or even a sense of impending doom when it's administered. This effect is typically brief, lasting only a few seconds. However, as nurses, we need to be prepared for this reaction and provide them reassurance. I also want you guys to remember that it has a short half life. And so, how we administer adenosine is we must give it very rapidly, like slam it in via the IV. And then you follow this up with a saline flush to ensure that it reaches the heart. If this was helpful, don't forget to follow along for more pharmacology education.